Hi, my name's Gabe Scheffler, and I'm an associate professor at the University of Miami School of Law. This is a short preview of a working paper that I'll be presenting on November 30th at the Harvard Health Law, Policy, Bioethics, and Biotechnology Workshop. The paper is titled Healthcare Reform and Two Conceptions of the Right to Healthcare. I decided to write this paper since I've been struck for a while now by the disconnect between, on the one hand, this kind of fierce moral sense that many supporters of Medicare for All have, that it's the only healthcare reform plan that can secure the right to healthcare, and on the other hand, the public debate over Medicare for All, which is largely focused on empirical questions, like whether it's politically feasible and what its effects on healthcare spending would be. This paper is an attempt to explain what I see as the main normative difference between Medicare for All and what I refer to as the incremental reform proposals. Namely, Medicare for All's focus on limiting inequality in healthcare access rather than just providing a basic package of healthcare benefits. This distinction, in turn, reflects a divide among different accounts of what constitutes a just distribution of healthcare. So just as background, Democrats have put forward a dizzying array of healthcare reform proposals over the last year or so. At the risk of oversimplifying, I group these plans into two general categories. The first type of plan, known as Medicare for All, would create a new universal federal health insurance program that would be far more expansive and generous than any program that currently exists. There are a few different versions of Medicare for All out there, but I focus primarily on Senator Sanders' Medicare for All bill. The second category of plans are sometimes referred to as incremental proposals. These would expand coverage while preserving key features of the existing healthcare financing system. Again, there are a number of different variants of incremental proposals, but I focus primarily on President-elect Biden's plan. My central argument is that Medicare for All and the incremental proposals reflect two distinct conceptions of the right to healthcare. These conceptions, in turn, differ in terms of the scope of the right to healthcare and what it entails. In brief, Medicare for All reflects what I call the right to equal access, which suggests that unequal access to healthcare is itself morally objectionable, at least to some extent. The right to equal access is egalitarian in the sense that it supports some level of equality in access to healthcare. By contrast, the incremental proposals reflect what I refer to as the right to a decent minimum, the idea that the right to healthcare requires access to an absolute set of healthcare benefits, and that there's nothing morally objectionable about inequality in access to healthcare in itself. In other words, as long as everyone has access to the decent minimum, there's nothing wrong with some people having greater access than others. The right to a decent minimum is grounded in the notion of what philosopher Harry Frankfurt refers to as sufficiency, the idea that what is morally important is that people have enough, not that some people have more than others. The divide between these two conceptions of the right to healthcare helps to explain two important differences between Medicare for All and the incremental proposals. First, Medicare for All would nearly completely eliminate private health insurance, while the incremental proposals would not. Second, Medicare for All would nearly completely eliminate cost sharing, like copays and deductibles, whereas the incremental proposals would not. Now, of note, prohibiting most forms of private health insurance and cost sharing aren't necessary features of single-payer healthcare systems. Many other single-payer systems don't have these features. But if you understand Medicare for All through the perspective of the right to equal access, then these two features are indeed necessary for at least some categories of services, since the right to equal access is concerned with limiting inequality in access to healthcare. For instance, cost sharing creates financial barriers in accessing care, which disproportionately affect the poor and the sick. Similarly, private insurance contributes to inequalities in access, since wealthier people may obtain supplemental coverage that provides access to benefits that aren't covered by the public scheme or provides other perks, such as greater choice of providers or access to more comfortable facilities. Eliminating most forms of cost sharing and private health insurance would thus address two important sources of inequality in access to care. By contrast, the incremental proposals approach of preserving private health insurance at cost sharing reflects the right to a decent minimum. This conception of the right to healthcare is compatible with requiring people to pay some amount of out-of-pocket costs when they see a healthcare provider, even if doing so contributes to inequalities in access. It's also compatible with allowing private health insurance, as long as doing so doesn't undermine access to the decent minimum for everyone. Examining these two conceptions of the right to healthcare therefore clarifies what's at stake in the debate over the future of healthcare reform. Not just concerns about political feasibility or economic projections, but also different moral or political values. So thanks so much for listening. I explored these issues and others in greater depth in the paper, and I'd be grateful for any feedback.